When customers come into the Bell branch, I would like them to know that it's not just a place they can do their banking. They can come laugh with us, cry with us, pray with us. We want to be their friend, not just their bankers. My name is Courtney Frazier, and I'm the Bell branch manager. Happy banking is different because our level of customer service that we offer to our customers and the personal relationships that we develop with our customers.
So this is actually a grant that the mandate is to set up a clinical research network across West Texas. And basically there's a lot of different ways that we monitor the flu, but this clinical research network would be focused on flu in a local area. It's focused on the Texas Panhandle, West Texas. Most of our surveillance mechanisms that we have in the United States are either regional or statewide or even national. And what we know about the flu is that it actually affects a community based on what community or local factors are. So the hope would be that by being able to establish this local research network, that would be able to find out more about how influenza affects communities in a defined geographic area, as well as be able to have a vehicle for starting new research projects, being able to use this network to open up other research projects.
Do I understand it then that it's kind of like a registry or an epidemiological database?
Not exactly.
Okay.
The backbone of the network are actually clinicians and clinics in West Texas. And we're starting off with a relatively small number. We've got participants from El Paso and Odessa and Lubbock and here in Amarillo. But as opposed to like a cancer registry where the information is collected from lots and lots of clinicians, and then the research is applied to the information that is collected, what we're actually doing is we're using this backbone of clinics to actually roll out research projects. Some of those are epidemiologic projects. As a matter of fact, one of the projects we've worked on for 2 years now, we're going to be able to expand and be able to offer at a few new locations because of this grant. And it's an epidemiologic study. It has it also looks at how MRSA and influenza interact with each other. So two common organisms or two common pathogens. It lets us be able to open up some more understanding of what types of strain are circulating in a local community. Right now, no place in West Texas, with the exception of the state lab in Lubbock, can we actually do influenza substrain typing. That's something that we've actually started doing at our lab here, and this grant will be able to help support that, so that when the Public Health Department wants to know, all right, do we have H1N1 circulating this year, do we have H3N2, we can actually tell them. And that's something that, again, before we started the West Texas Influenza Center, we didn't have the capacity to do that locally. What we had to do was send it to the state lab. There's sometimes a little bit of a delay just because the state lab has to process a lot of samples from a lot of places. And this allows us to have that under local control.
How, I heard you talking a little earlier, how does the flu potentiate the Staph aureus?
Well, there's two things. The two bugs kind of feed off of each other. First of all, the flu very commonly causes sloughing or loss of the typical protective lining of the airways in the lungs. And when that happens, when we lose that protective lining, then that makes it easier for different bacteria to be able to bind. So we see that there's a spike in bacterial pneumonias after or during influenza season, because people get the flu, they lose that protective lining because of the virus, and that opens the gate, if you will, for bacteria to be able to attach and cause infection. It's not just MRSA, it also happens with strep pneumoniae and MSSA. There's several bugs, Haemophilus influenza is a bacteria, there's several bugs that happens with. The bacteria itself, though, may also make the flu worse. The bacteria, things like strep pneumo and Staph aureus, actually possess a type of enzyme that the influenza virus needs in order to be able to effectively infect additional cells. And so it may actually be that the presence of the bacteria may make the influenza worse, and certainly we think that having influenza increases the risk of developing a bacterial infection.
So where does this take you with respect to kind of breaking that cycle? In other words, what does it do in the way of cure in terms of finding combined antibiotics and antiviral drugs? Does that explanation that you just gave us take us there?
Well, I think it's a step in that direction. And what I would suggest is that if we are able to quantify the amount of risk of complications from the flu when someone's colonized with a bacteria like MRSA or strep pneumo, then that opens the door that if that risk is high, maybe you take folks who are at high risk and are colonized with these bacteria and potentially try to decolonize them during the flu season so that they by doing that you'll be able to decrease your risk of developing those complications from the flu. Again, it's a stepping stone. Like most things in medicine, it's pretty rare that we do the research that is the end game. Usually it's a stepping stone. We do actually have a couple of other projects that are a little more end game, I guess. We have one project that we're going to be doing working with the immune plasma. It's actually an NIH project, but it uses part of the same network that the CDC money is helping to create, where we'd be able to actually treat patients who have the flu with this novel therapy of giving them back influenza antibodies in an attempt to decrease the severity of the flu. We have a study that we're working on, another study with the NIH, where we're looking at a combination of antivirals compared to the standard Tamiflu or also Tamivir antivirals for folks with the flu. So there are some of those end-game research projects that we're doing, but a lot of our stuff that we do is a stepping stone towards being able to improve people's lives and quality of life.
You're working to identify simple questions to ask patients to predict whether the patient has the flu.
Yes, sir.
And talk about that a little bit.
Sure. So one of the things that we see is that even though the flu is incredibly common, we don't have a good way of being able to diagnose the flu. Our options are we can use our clinical judgment, which during the middle of a flu season can be pretty effective. We can say, boy, you got a fever, you have a cough, it started just 2 days ago, I think you've got the flu. Turns out that that's right only about 30 to 40% of the time. We can do the rapid flu test. Oftentimes you go to your doctors, they'll stick a big Q-tip in your nose, and then 15 minutes later they come in and say you have the flu, you don't have the flu. The problem with those tests are that they're not real accurate either. They actually miss, depending on the strain of flu, but they'll miss somewhere between 40 and 60% of the cases of flu. If it's positive, that's usually pretty good information. If it's negative, though, then it's not enough to truly say that someone doesn't have the flu. We do something called PCR, which is a test that I do in my lab, the state lab does, and that PCR test can actually be very accurate for diagnosing the flu. The problem is it's expensive and it takes a while to get back. Usually by the time we get the results back, the patient's already better. So we have to find a better way of being able to diagnose the flu, and that's where we would like to be able to come up with predictors that may be able to increase or decrease the likelihood that an individual patient has the flu. And if I can give you an example, 2 years ago when we first did this, first started looking at this, we looked at a group of patients who had the rapid flu test was positive, and we found that in kids, if when kids had a heart rate that was greater than 140% of what the average for their age is, then they would actually be much more likely to have the flu than kids whose heart rate was normal. Now, the hypothesis there is that there's something about the flu that as it causes this cytokine release, this storm of inflammatory chemicals produced by the body as a response to the flu, that drives the heart rate. So one of our projects that we're doing that's more of an epidemiologic project, but we're looking to see if we can take a combination of vital signs like heart rate and respiratory rate and blood pressure, along with symptoms, self-reported fever or difficulty breathing or cough, and come up with a combination that's able to help us predict who truly has the flu and who doesn't have the flu hopefully better than what the rapid tests that we do now are.
Tell us quickly what the PCR test is. It's a DNA test?
It is. Now, technically, influenza is an RNA virus. It doesn't have DNA. But what we end up doing is basically you take the RNA, or the nuclear material of the virus, and from a sample, just from a nasal sample, and you basically duplicate that that nucleic material. And so as you increase the amount of nuclear material that's there, that's that polymerase chain reaction, or PCR, then eventually you get enough that we can detect certain genes that are present there. And that's actually how we're able to tell, is this influenza A H1N1, is it influenza A H3N2, is it influenza B? It's that duplication of the material to where you have enough volume that you can actually test it that makes that PCR work.
How do the hospitals here fit into this? I say here, meaning in your study area.
Sure. So the we have one big our NIH trial where we're looking at H1N1 that we're working specifically with one of the hospitals in town, because that will actually that study will be performed in an inpatient setting. Here at the Texas Tech Clinic building, we don't have hospital beds to be able to keep the patient, and if the patient's in the ICU, they need to be in the ICU. So we're able to work with the hospitals in being able to lay out those kinds of research projects.
Okay. What else do we need to cover about this? Because I do want to ask some questions about flu and flu season and that sort of thing.
Well, you know,
Is
I
there
think
anything else on this that we need to go with?
No, I think that we're just kind of excited that this gives us a real boost in being able to bring some, I think, cutting-edge research to the Panhandle regarding flu. For example, in that NIH trial, the other sites that are involved are actually Harvard's Mass General and Duke and Vanderbilt, and Emory's in on that one, Texas Children's, and then Texas Tech and Amarillo. And so I think that's good that we're able to use this network, hopefully, to be able to bring in some research opportunities and even improve clinical care in the Panhandle that we weren't able to before.
Okay. We pause it.